Thank you very much for attending this evening's presentation of MyDNA-Halo. My name is Dr. Lewis Meltz, and this presentation this evening is for those who are medical doctors, osteopathic physicians, physician's assistants, nurse practitioners, and other healthcare professionals interested in how pharmacogenetic testing can benefit your office. I'd like to introduce our executive team. First, Sunil Wadhwa, our co-founder, CEO, and president, and Ken Newton, co-founder and COO. Between the two of them, they have many, many years of experience. They've been national speakers, seminar leaders, requested national trainers, and between the two of them, over 50 years of combined experience in direct sales and top sales leaders in organizations they've represented. And my co-host for this evening, Dr. Doug Tuman. Dr. Tuman is an ankle and foot specialist, practices in the Hudson Valley. He has 30 years of experience, operates 6 successful practices, and his passion has always been in the area of health and wellness and changing lives. This is how pharmacogenetic testing is going to influence not only patients, but the way physicians practice in the future. I am a board-certified chiropractic orthopedist. I've been in practice since 1983. Now, I don't have a DEA license, but I've seen many, many patients over my years of practice with spinal stenosis, arthritic problems, headaches, sleeping problems, who take anti-inflammatories and opiates for their problems. And oftentimes they confide in me how these medications simply aren't working or aren't working the way that they were promised or intended. This sort of test can change that in the very, very near future.
Thank you, Dr. Meltz, and welcome to everybody who's on the line, our physicians and our medical professionals, our health and wellness team. Tonight we're going to introduce you to something that will be of great value to you in your practice, and the more you learn, we encourage you to learn as much as you can, the more this will benefit your patients and your practices as well. This is already being utilized in major clinics and facilities across the country, including the Mayo Clinic and Duke University and Vanderbilt University and major institutions. And the reason it's so important is because everybody's different, and there are no two of us that are the same. And as the Human Genome Project has brought us incredible information, what we've learned is that every person responds to medications differently, and our differences are so important to find out. Now we can find them out. So what we'll be learning is, just like our fingerprint, our DNA imprint is different for each individual, and the markers for medications are extraordinary, from Hippocrates to others that have given us famous quotes. We understand that there's such a great variability among individuals, and we know as physicians, science, our medicine is a science and art combined, and the two are really converging as we talk about this personalized medicine. So pharmacogenetics, as we know it, is the study of genetic variation and the influence that it has on the individual's response to medications, prescription medications. So this science allows us to predict a response to drugs based on our individual genetic markup. This also allows us to do precision prescription writing, as it helps prescribers individualize drug therapy, and while we're doing that, decrease the chance for ADRs, adverse drug reactions and events, while most importantly increasing the effectiveness of the medications. So why should physicians test their patients? Well, to eliminate the trial and error. Personalized medicine is about accurate diagnosis, prognosis, and treatment, and that can save lives, because we all want to begin our treatment protocols with the right dose of the right medication at the right time for the right patient. And we've been doing one-size-fits-all medicine, and it's time to treat people like individuals, which enhances patient care, which enhances satisfaction, compliance, reduces liability to the physician, as well as reducing liability to the person taking medications, while enhancing reliability of our treatment plans. So this is all critical information. And as always, the more information that's available, the better physicians and healthcare practitioners we can be. So this pharmacogenomics allows us to provide this tailored drug therapy or precision prescription writing using genetically determined variations to minimize side effects. So what it allows us to do in our practice is allows the right medicines, which allows for more powerful medicines, targeted therapies for specific diseases, increasing our therapeutic effects while decreasing damage to the nearby healthy cells. It allows us to use better, safer drugs the first time because the patients aren't going to be coming in with medications that aren't working, aren't getting the desired results. And of course, recovery time will go down, safety will go up, and likelihood of adverse reactions goes down, and in many cases eliminated, which is a huge savings to the healthcare system as well as our time in the patient's body. So more accurate methods of determining appropriate drug dosages are in our power now with this pharmacogenetic testing. So the current methods of basing dosages on weight and age are being replaced with dosages based on an individual's genetics and their genetic variations and how well the body processes and metabolizes the medication and the time it takes for the body to have medicines being effective in our body. What it will do for you in your practice, it will allow you to begin to individualize drug therapy as well as decrease the chance of an adverse drug event, or the ADRs, adverse drug reactions as we know them, while increasing the effectiveness of any medication that you give to your patients. So this is the most important path towards personalized medicine because, as we know, with 4 billion prescriptions a year written, the more we can personalize this, the better results we will get. So why should physicians test their patients? Well, right now, we want to really do the best for our patients, eliminating trial and error, not getting the phone calls in the middle of the night or whenever it may be that the drug isn't working for their pain relief, the drug causing a reaction. We want to know that for as much of a time as we can, we're getting the right medication and the right dosage the first time, because I think anybody on the call right now wants to start a patient off on the wrong drug and the wrong dosage most of the time. We'd like to eliminate this one-size-fits-all medicine, which is what pharmacogenetic testing and medical management does, whether it be for statin medications, blood pressure medications, medications that we use in psychiatry, cardiology, pain management. We'll be able to have better, safer drugs the first time and more accurate methods of determining appropriate drug dosages. We're going to be able to recognize if someone, as Dr. Meltz will talk about, is metabolizing medication too slow, too fast, or just right, just like mama bear, papa bear, or baby bear. We want to know exactly how medications are individualized and metabolized, and that will create the individualized medicine approach. So, Dr. Meltz, I'm going to pass it back to you.
Thank you so much, Dr. Tuman. And Dr. Tuman is so very right. Because of the medication management based on age and weight and possibly diet, now we have an additional marker on the genetic composition of the phenotype, knowing how that individual is going to metabolize that drug rather than just hoping how we expect it to function in that individual. Now, the FDA has posted 130 black box warnings on different medications that they recommend either testing early on or shortly after the therapy is prescribed. But there are also 16 frank black box warnings that require pharmacogenetic testing prior to prescribing because of the damage and the harm it can cause without having that added value of understanding. Now, why should we really care about this type of testing? Understand, there are over 2 million avoidable adverse drug reaction hospitalizations each year. Now, this doesn't include the people that silently suffer at home or those that succumb at home. These are those that are just hospitalized each year. There are over 106,000 avoidable ADR fatalities each year as a result of taking the wrong medication. The FDA reports there is an excess of $136 billion spent in avoidable annual costs treating ADRs. And of those who reside in nursing homes, those residents, there are 350,000 ADRs that occur each year in that population. Now, the more drugs a person is taking, the greater the chance of an ADR. And the average Medicare patient takes between 5 and 8 drugs on a daily basis, some as many as 20 drugs each day. And we know that an individual who is taking 11 or more drugs has a 96% chance of experiencing an adverse drug event. Now, Pharmacogenetic testing can significantly reduce these statistics, yet we're unnecessarily subjecting our patients to these avoidable ADRs, even fatalities, because of not testing. So we understand that when we do this test, we can then learn more about the phenotypes of patients being prescribed to. And there's four general categories. There are ultra rapid metabolizers who demonstrate an increased enzyme activity. There are extensive metabolizers, those who are considered normal, and those that are intermediate have an impaired function, and poor metabolizers who have essentially a non-functional level of metabolism. Now, this is considering the 57 different enzymes of the CYP450 enzyme family. And once we've tested these panels, we have the ability to understand how upwards of 95% of drugs that are metabolized will function in an individual after testing. Now, we're looking at those substrates or drugs that are inhibitors. It's a medication that slows the metabolism of another medication, which may result in excessively high blood levels, extended effects, and related toxicities. Those who are inducers, that's a medication that boosts the metabolism of another medication, which may result in accelerated breakdown, increased clearance, shortened duration, and subtherapeutic levels or withdrawal effects. So it may also cause an increased activity of a prodrug. And those are the prodrugs that are the ones that function only after they've reached the target organ, usually the liver. They're biologically inert when consumed, but once the metabolic pathway is activated, then the magic happens and they turn into their active form. And these can also create problems for someone, especially who is a non-metabolizer. So as we look at this chart here, we can understand how a prodrug needs to be metabolized at the 2D6 pathway. And this is for an example of codeine. Codeine is inert until it's broken down in the liver, which turns into hydromorphone or morphine, or an active drug, which is Prilosec, which would have similar function. But a poor metabolizer in the prodrug category would have a possible accumulation of the drug. Whereas a poor metabolizer in an active drug, it has that accumulation and they may need a lower dose. Similarly, those prodrugs and ultra-rapid metabolizers, it has a good efficacy, but it could have a very, very rapid effect. These are the people that complain that they're knocked out quickly with a low dose pain reliever or muscle relaxant, whereas in an active drug, it may need to have a slow release formulation for its intended effect. So we can see on the chart here that once we understand the phenotype of an individual, and for this example, the 2D6 pathway, for example, someone using Elavil, a poor metabolizer may need only 75 milligrams for the same intended effect of an ultra-rapid metabolizer who may need 130 milligrams. Understanding the variability is the ability to understand how they're going to function and respond. So we have a case study here. Take, for example, codeine. A 30-year-old woman, she gives birth, normal childbirth, has an episiotomy. Her physician recommends codeine for pain. She begins breastfeeding her infant. 2 weeks later, her infant dies. On autopsy, it's revealed that this woman was a ultra-rapid metabolizer of the 2D6 pathway, and had the physician been aware, and we'd like to say being forearmed is the same as being forewarned, a different analgesic could have been prescribed and possibly have saved this infant's life. Now we understand this is an article from Pain Medicine News, April 2013. When they looked at twin pairs, and you probably couldn't get closer genetic composition than in twin pairs, but when they studied twin pairs who experienced migraines, they found that there was a 39 to a 58% genetic contribution on how that was expressed in the way they metabolized drugs. And for those twin pairs who had low back pain, the variation was 21 to 67% contribution in the metabolic pathways that they exhibited. And as other studies are followed, patients taking 8 drugs, they calculated that in 63% of the patients at least, there were 476 different drug interactions possible by just taking 8 drugs. And so we understand that there's a huge variability on how not only twin pairs function and metabolize, but also the more drugs an individual takes, the greater chance of changes occurring. Now, we also know that in 10% of the Caucasian population, they're ultra rapid metabolizers of codeine, but only 1% of patients are even aware of this potential drug-drug or drug-gene interaction. Another very good important reason to begin pharmacogenetic testing. Here's another example using Coumadin. This individual is a 65-year-old woman. She's diagnosed with atrial fibrillation. So to reduce her stroke risk and also for any bleeding or clotting events, her physician places her on warfarin therapy. Now, early on, her INR levels have to be checked very, very closely in addition to her age and her sex and her weight and her diet. But with pharmacogenetic testing, this person's INR levels could be monitored very, very easily early on, understanding if she is an ultra rapid or even a poor metabolizer of Coumadin or warfarin, and perhaps alternatives and other recommendations made. So we can understand that the 2C9 pathway is used in addition to the VKORC1 pathway genotyping to understand exactly how this person would respond to warfarin and minimize any of those bleeding risks or subsequent hospitalizations. So again, a very, very important reason to begin performing pharmacogenetic testing. And it's to understand the testing is applicable in 70 to 75% of patients to control anticoagulation. So again, this is a very important test because the bleeding events that occur annually. Prozac, clinidine, 9-year-old boy is ADHD diagnosed. He's placed on these two medications. He develops symptoms of low-grade fever, incoordination, seizures, and then culminating in an epileptic attack that kills him. Now, had this young man been tested in the 2C19 pathway, it may very well have been understood what type of metabolizer he was and an alternative recommended. So again, 4 dramatic examples of the value and the importance of pharmacogenetic testing. It also reduces liability. You can watch on the television or listen on the radio any time of the day, and there are law firms that are actively trolling for litigants, looking for people who have either experienced an adverse drug reaction or an uncomfortable side effect, or maybe an unsightly blemish caused by the side effect, and they're looking for compensation and for their recovery. So again, risk management reduces liability to the physician, another important reason of why a lot of us oftentimes practice defensively. And the unpredictable and influence that a medical practice will experience because of a lawsuit is unsettling. To present any sort of liability like that, this type of testing will minimize those disruptive impacts on our standard operating procedure and also in the course of our practice. So this test is available. It's easily performed in an office. It's a non-invasive buccal swab. Recently approved by the FDA, Medicare pays for this test 100%, no copay and no deductible. Now, most carriers will cover this test with the lab deductible and the normal deductible and copays, but the information that's available is immeasurable. The medical necessity is that of 2 medicines on board. One can be a over-the-counter aspirin, Tylenol, Advil. A simple indication on why the test is being performed. When it comes to a pediatric patient, no diagnosis required at all because it establishes a baseline for future drug medication, the guideposts and the milestones needed for that individual's safety. And with those drugs that have black box warnings like codeine and others, no question, a pharmacogenetic test would certainly be in order and of necessity. No longer experimental or investigational. It's a test that it's approved by most insurances. The laboratory we are working with makes available the PharmD, the clinical scientist, and the medical director for private or individual consultation to discuss the drug-drug, the drug-gene interaction, and also the recommendations for other alternatives. Now, the financial exposure to patients, it's a one-time lifetime test. It's a single test that's performed once. And now with the panel that we're testing for 9 different enzymes, this tests for about 95% of the drugs being prescribed. So when compared to other routine tests, CBCs, UAs, cardiac risk profiles, and other chem panels, you can see where these tests that occur several times a year can become quite costly. Whereas this one-time test will then help predict and create the baseline for future medication. So you need to weigh the risk and the benefit. It's a one-time cost to a patient. It offers peace of mind for the patient and also to the physician and the prescriber, better patient satisfaction, better compliance, better outcomes, and for you, less liability. So we have a little diagram here on how the process works. So like I said, it's a simple cheek swab. It's sent to the laboratory in a prepaid Federal Express envelope, delivered to the lab. The lab does the testing. Within 3 to 5 days, results are then emailed or faxed or conveyed to the doctor through a integrated EHR. Doctor can then discuss with the patient with an additional visit or added face-to-face time or just integrated into the file. Now, the laboratory we use not only specializes in DNA testing using the Luminex 200 platform, it's the only FDA-approved platform. They also perform pain management testing, drug testing, forensic toxicology, therapeutic drug monitoring, biologic monitoring, and other medical surveillance. So this isn't just a one-stop shop for your lab. It's not a big box lab where there's no one available. There is available people to speak with. The laboratory is CLIA certified through the Department of Health and Human Services for Medicare billing. It's CAP certified as a clinical and forensic drug testing laboratory and has SAMHSA accreditation working with OSHA. It's approved in every state that requires approval. It's licensed in every state requiring licensing. It's certified in every state that requires certification. And those that simply require registration, this laboratory is registered as all. So what I'm saying is that the laboratory is able to function unrestricted, unfettered in every state that you might be referring from. Now, we also have, as an added value customer service benefit, an NDC-coded, registered DNA collection wet kit that, when billed through the patient's pharmacy benefit, can reimburse the provider between $400 and $500 for using this medicated wet kit. Now, this is not available for Medicare or Medi patients, but those whose insurance do cover the use through their RX benefit, $400 to $500 every time a healthcare provider uses this kit. For those that are non-insured, underinsured, there are free dry kits available from the lab to use. But again, an added value of having a wet kit at your disposal certainly is a compelling reason to consider using the laboratory. As I said, clinical laboratory scientists, the PharmD and medical director are available for consult. And one additional added value benefit, the laboratory obtains pre-authorizations for all lab tests that they might perform for you. What this means is that those patients being tested, they take the burden off your office. I mean, it's a pretty cumbersome ordeal for any of your staff to be doing insurance authorization. This just takes it off the table for you. If you want to send in one patient at a time, or alphabetically, by the week, by the month, by the thousands if you wish, the lab will perform the prior authorization necessary. It takes about 10 to 14 days for that process, but nonetheless, they do this at no cost to the provider to obtain pre-authorization for you. So these are the differentiators. The laboratory has 30 years of experience. It's considered one of the country's leading specialty laboratories in this area. It's one of 7 SAMHSA accredited laboratories in the United States. It's recognized for its scope of testing and its accuracy of results. And as for scientific expertise and innovation, they're considered experts in their field of doing this level of testing. And the laboratory offers the specialized, unique NDC-coded wet kit that will allow the healthcare provider to be reimbursed between $400 and $500 each time the wet kit is utilized to obtain the specimen. And it's, again, these are for non-Medicare cases, but nonetheless, it's a very, very nice way to add an income stream to your practice. So implementation, what you want to do is get back with the person who invited you to this call. It's simple as that. Be happy to speak with you, set up a conference call, answer whatever questions you might have. And it's an extremely easy process to set up your office. The lab will perform that tedious process of getting all your patients pre-authorized. Your rep will help you set up with this wet kit so you have the ability to earn an additional $400 to $500 on some of the tests you perform. I want to thank you, Dr. Tuman. Thank you for joining me this webinar. We want to thank you for your consideration, your valuable time, considering how to implement pharmacogenetic testing through MyDNAHalo. If you are interested in being part of our scientific advisory board, we certainly invite you to send an email to mydnahalo@financialhalo.com. That's mydnahalo@financialhalo.com. If you have any interest at all, get back with the person that invited you to this call or send an email. Again, mydnahalo@financialhalo.com. We'd be more than happy to explore how you can implement pharmacogenetic testing in your practice. On behalf of Dr. Tuman and myself, Dr. Lewis Meltz, I want to thank you for this call. You have a wonderful day. Bye-bye.